Haemostasis is one of those topics that can come up in both the primary and the final FRCA. So I wanted to start off by going over a whiteboard drawing which you can reproduce very easily from scratch. I've simplified the diagram to only include bits of haemostasis that are the most important and relevant to clinical practice and to the exam. The question for haemostasis may come up on its own, or it may come up as part of a broader question on the pharmacology of drugs affecting haemostasis, such as antiplatelet drugs or anticoagulants. The theory I follow here is the cell-based model and the coagulation pathway model, neither of which you need to know in depth to pass the exam, so don't worry about knowing the exact details of everything. The three main key words that you need to remember are primary hemostasis, which is also known as the formation of the platelet plug, secondary hemostasis, which is the part of the fibrin clot formation, and fibrinolysis. Now, within the platelet plug formation, there are three additional steps that we need to remember. That's platelet activation, platelet adhesion, and platelet aggregation. We can use these keywords as a skeleton and hang the details of everything that we need to know onto this. Now let's start off by drawing a blood vessel and a platelet, and imagine that in this blood vessel there's an injury that's occurred. So here is our blood vessel. This is the injury. We'll draw a platelet. Now each platelet contains dense granules. These are small packages which contain molecules. They also contain three receptors, and these are the P2Y12 receptor, the thromboxane A2 receptor, and the GP2B3A receptors. When an injury occurs, there are three things that are exposed. One is von Willebrand factor, the other is collagen, and finally tissue factor. Collagen is what causes the platelet to become activated, and then that platelet will adhere to the von Willebrand factor, which is attached to the vessel wall, and this is known as platelet activation and platelet adhesion. When the platelets adhere to the vessel wall and they get activated, they release these dense granules which contain four things. Number one is calcium. Number two is serotonin, or 5-HT. Number three is thromboxane A2. And number four is ADP. Thromboxane A2 and ADP are both involved in the aggregation of platelets. So they act on thromboxane A2 receptor. So thromboxane A2 acts on the thromboxane A2 receptor, and the ADP acts on the P2Y12 receptor. And by doing so, they cause more and more platelets to become activated. And you can imagine that this reaction that occurs is almost exponential, where platelets activated over time leads to an exponential reaction of platelets being activated. Now let's turn our attention to tissue factor, which activates clotting factors around the same time all of this is happening. The tissue factor causes a reaction that activates both the intrinsic and the extrinsic pathways. The pathways are not important themselves, but it is important to note that they both lead to the activation of factor 10 into factor 10A. Factor 10A then causes the conversion of prothrombin into thrombin, which then leads to the conversion of fibrinogen into fibrin. This is known as the secondary hemostasis, or the formation of the fibrin clot, and this is the mesh-like structure and stabilizes the clot itself. Now the last bit, which is fibrinolysis, is the breakdown of clots. To break down clots, an inactive protein called plasminogen gets converted into plasmin. And the enzyme that catalyzes this reaction is known as tissue plasminogen activator, or TPA for short. Now you can think of plasmin as like a bit of a Pac-Man, which will munch away at the fibrin and causes the clot to break down. When fibrin breaks down, it turns into fibrin degradation products, and one of which is D-dimer. So to understand the clinical relevance of it all, first of all, we've got von Willebrand's factor, which is deficient in patients with von Willebrand's disease. It's an inherent condition with variable penetrance and is the most common blood clotting disorder with a prevalence of around 1%. The platelet receptors here, they allow you to classify antiplatelet drugs. For example, which acts on the P2Y12 receptor, you've got agents such as abciximab, eptifibatide, and tirofiban, which work on the GP2B3A receptor here and prevents the platelets sticking to each other. And finally, you've got the classic non-steroidal anti-inflammatory drugs which inhibit the production of thromboxane A2. Now, calcium is very clinically relevant as it's why we give calcium when we resuscitate with blood products. The intrinsic pathway is tested by the APTT and the extrinsic pathway is tested by the PT. Both of these are on the coagulation profile test that we do. When we give FFP, we're increasing the factors that are involved in this part of the reaction. And when we use DOACs and warfarin, they inhibit the factors that act here. Now, when we give fibrinogen, that's to increase the supply of fibrinogen so that we can form more fibrin. And finally, drugs that act on this section include tissue plasminogen activators and tranexamic acid. Tissue plasminogen activators are drugs that push the reaction this way, thereby forming more plasmin and causing more clot breakdown, something that you might want to do when there is a clot blocking the coronary artery in an MI. An example of such a drug would be streptokinase. Tranexamic acid inhibits this enzyme, thereby reducing the activation of plasminogen and reducing the formation of plasmin. By reducing the formation of plasmin, you get less clot breakdown, hence why it's used in major trauma and postpartum hemorrhage. Just to summarize, we talked about the formation of the platelet plug, we talked about the stabilization of that clot, and then its breakdown. So with this simple diagram, not only can you describe the main parts of hemostasis, you can also classify drugs that act on the different steps in this process. If this is a physiology question, you can draw the whole thing out and even simplify it further. If it's a pharmacology question, you can just draw the antiplatelet drugs, for example, and the receptors, and thereby classify those. I know this diagram is a massive oversimplification, but the key points relevant to anesthetics are still present. Just practice drawing this out a few times for it to stick, or take a screenshot and just refer back to it. Thank you for listening, and I hope this helped with understanding the concept of hemostasis for an exam question. I'm still experimenting with which app to use and how to deliver the content, so if you have any suggestions, please leave them in the comment section below. Thank you.